Chairman, Carl Gugino, ladies and gentlemen. It's great to see old friends, and it's especially great for me to be here today because the Foundation for Orthodontic Research was my very first orthodontic meeting. Guess who was the speaker? Our good friend Carl Gugino, and he's always been ahead of his time. And it's such a great opportunity to come back and see some old friends in the audience and to hear Carl again. Every day for the last 33 years, I wind up my day in the office tracing patients. And it's a wonderful way to wind down. And it's always been great to have that Rocky Mountain orthodontic package sitting with me. Many times I'll sit in front of the patient and tracings that we learned from Rick and from Carl. Over the years, there have been a lot of changes, and I have learned a few things. And so this morning, today, I will talk about things that have helped me do it a little bit better, and we'll show you our state of the art. In the presentation today, I am acutely aware that case reports and expert opinion are very low on the evidentiary scale, and so I've tried to intersperse transparently in today's presentation some literature reviews, some research that we have done that is random trials, and moving it up into the evidentiary scale as high as we can. Here is Dr. Ricketts, Dr. Gugino's original Bioprogressive book. And in their book, they talk about two essential truths which characterize the orthodontic profession. First, and Carl talked about it today, is that changes in technique are inevitable. We know that and we've experienced that. And the second is the fundamental truth that biology does not change. And so in the presentation today, you'll see fundamental principles and philosophies that are deeply rooted in what we learned from Carl and Rick and from the founders of the bioprogressive philosophy and the zero-based philosophy. But you also see significant changes in techniques that have occurred. One of the advantages of being in the same place for a long period of time is you get to see long-term records. And here you see Betsy, who I treated 33 years ago when she was a young woman, and we now have 30-year records of her. She was treated before her daughter Betsy was born. Sarah was born. And we treated her when she was 10 years old, and now we're treating her two twins that fly down from San Francisco. And you learn a lot from some of these long-term records. Dr. Ricketts and Dr. Gugino would love to bring us cases that they had treated long-term. And at the end of the day, many times Dr. Ricketts would pull out these rat-eaten model boxes that were from his garage, but the models were beautifully preserved. And he was an ardent student of the literature and also of his own cases. Here is one of those examples where we have 25-year records of a young woman in her late dentition with full skeletal class 2 malocclusion, deep bite with 100% deep bite, severe imbrication on the lower anteriors and at least 9 millimeters of crowding, where through some of the techniques that he has shown all of you and us over the years, he was able to reduce it fully in over a period of time. And here we have the retention records, cephalometrics, years afterwards, and here we have the long-term records with the old 4-to-4 and then the post-retention. And as we look at these, we think to ourselves how great it was for the time that it was, and we learn from it, each with our own biases. What could we do differently? What maybe could we do better with some of the technology today? We look at a facial structure over here, and Dr. Ricketts would also enjoy showing cases that were not so successfully treated. Sometimes his, sometimes others. Here's one that came in to see him many years ago for a second opinion. And he traced the records showing her as an 8-year-old with a full skeletal class 2, same convexity as the previous person, 8 millimeters, little different facial pattern, and 5 years later, 100% relapse after 5 years of orthodontics. Here you see her another 2 years later when they decided to do extraction of bicuspid in order to resolve it. And we see her with 100% relapse 2 years after that. We then see her with a surgical treatment plan, now starting age 7 or 8 or 9, now she's 18, and we see her with 100% relapse there. And we look at her facial structure, and we know we could do better. Dr. Ricketts was very critical of orthodontists who he felt sometimes were exacerbating possibly pre-existing malocclusions and patients with perhaps temporomandibular joint problems by some of their mechanotherapy that they were using. Here is a more simple case to illustrate the point. Shortly after I took the advanced course of Dr. Ricketts, 2 weeks, many of you may have taken that, I was invited by Bob Berger, the president of the American Association of Aesthetic Dentistry, to present the material to their academy. And I was showing all of the things that Carl talked about today. Segmental mechanotherapy and anchorage setup and a bioprogressive way of doing things. And at the end of the meeting, Bob called me and said, "Do you mind if I bring my daughter over?" His best friend was an orthodontist, and both of them showed up into my office, and here she was. They brought me the records. It was a young Roseanne, who was his daughter, with a class 2 division 2 type of a deep bite and early mixed dentition. At that time, they had recommended waiting for treatment, obviously something that we all don't do today. And you can see, based on all the things we've learned, what a relatively simple case that would be to treat today if it's intercepted early. Waiting for it, however, until permanent dentition came in made it more difficult. And now 2.5 years into treatment, she's sitting with a full class 2 malocclusion, 2 years into braces. They fully haven't, the malocclusion is not resolved. The condyles are maybe not even fully seated in the fossa, so it's even more of a class 2. And here's where Dr. Ricketts would teach us to go ahead and call to put those little segmentals on, set up anchorage on the lower anteriors, and using the principles of anchorage that they taught us to reduce the malocclusion even in some of these complex cases. And was very adamant that class 2 in the traditional Tweed mechanics, where you have 2 arches against each other and pulling them, is just going to continue like a dog chasing his tail to open up the facial axis and exacerbate the malocclusion. And so we went ahead and, with the orthodontist's permission, and with orthodontist was blaming it on the daughter, that she was terrible with the hygiene and didn't wear rubber bands, and the orthodontist was burned out, and they were just happy to have a transfer over with everybody's endorsement. And so in a very short period of time, we were able to do everything we had talked about using that mechanotherapy. And there she is. Here we have her many, many years later. I'm showing the stability of her. She was so infused by the experience that she went through, and with her father's background, that she ended up going to dental school, became a dentist. She's now a pediatric dentist, and here is 20 years later, her dentition. She's practicing in Torrance, and you can see the stability, you can see the nice airway, and you can see there she is before, a little lateral bonding, there she is after, and here she is with a little facial palsy recently that has since resolved, but the nice changes. And so Dr. Ricketts, Dr. Cugino showed us that by embracing cephalometrics, using the VTO, even extreme cases like these that he was talking about, that outer 30%, recognizing that everything is related and taking into consideration long-term growth, adding the frontal film, we were able to attack and address appropriately severe malocclusions. Dr. Ricketts felt that the cervical headgear almost acted as a functional appliance, and rather than extract teeth, he felt that correctly adjusted, you could extrude the molar sufficiently on the upper, using that headgear 14 hours a day to almost allow the mandible as an activator. And Carl, he showed me composites of 50 cases treated with the Bimler, 50 with the bionator, 50 with the cervical headgear, and when you trace them long term, you could hardly tell the difference. The debate continued in the literature, and you can see the changes before we even begin to put the braces on that can occur orthopedically. The corollary was true with class 3s, where you have a tendency towards the mandible growing. You talked about the cranial base deflection, the mandibular arc, the corpus length, and all the factors that contribute towards the class 3. Here, the young girl was again set up for serial extraction, and by the time we inherited her, she had complete edge-to-edge type of a bite, and you could see very little space for the permanent teeth to come in. Using the principles that we talked about, you can see the complete blockage out of the canines, and they're using the techniques that we've talked about and that you have learned. We were able to reduce the malocclusion and develop the broad arch, and things were good. I fly helicopters and fixed-wing planes, and if there are any pilots in the audience, you'll know that no pilot flies without a flight plan. And Carl was talking about earlier that as the orthodontist, we need a plan. And for us, it's the VTO, the long-range forecast, and some of the slides that we talked about. And so, when we look at these young kids at age 4 years old, we want to almost visualize them at age 24, and what we anticipate and how we think. And part of the exercise of going through what you talked about, Carl, and what Rick talked about, was the attempt. And critics say that the long-range forecast is not accurate, but at least it's a plan to which you can measure against. And I remember so many times at the advanced courses, Dr. Rick is taking long-term records from patients and challenging orthodontists, tracing them out and how close he would come. And sometimes he would miss, but the point he was making, it was a useful tool. There's the same woman 24 years later, and if we can visualize it at the outset, begin with the end in mind, we're ahead of ourselves. And so we would take little young kids like this, attempt to visualize them, work them up with the RMO or your own BTOs, and be able to produce results like that before we even put some brackets on them. Staging it. Critics of the phasing of orthodontics talked about, well, it takes so long, and why are we going to start them at age 5, and you're going to burn the kids out. And Carl and Rick were quick to tell us that it's not at all that way. There's a very short period of time in each stage, and there's very little in between, and it's a wonderful service and how much we can benefit from that. So here we see her, and now we could go and put on some little fixed appliances and do the detailing and finishing, and there's not that much to do. A lot of the orthopedics is done. So we would accumulate these class 3s that you see over here, intercept them at an age early. This one I think was 3 years old. And we would do our long-range projections like what you see with runaway mandibles. We would intercept them, put them into a normal class 1, and there you see 20-year records with him over a period of time. With the phasing of treatment, where at the appropriate stage you can go ahead and put on some brackets for a relatively short period of time and get a beautiful result with nice stomatognathic function and a beautiful airway like you see over there. So things are good, and it's hard to improve a lot on some of those. However, when Carl talked about that 30% on either side, the more complicated cases, some of the adult cases, and in those respects, there have been significant improvements, and I brought some of them today to show you in an attempt to help. Here would be one such case who came in, and on at first glance, it appears like a not very severe type of a bite. She's got a mildly darkened buccal corridor, a little bit of a reduced lower facial height. She came in with some handheld models, and she had had 3 or 4 different previous opinions, running the gamut of all of the things that you've seen over the years. Full class 2, division 2, deep bite, blocked out bicuspids, and there you can see with the little light forces and the utility arch wire, placing in the torque, the rotations, the tips, all of the things that we've learned over the years, reducing it over a period of 2 years. And at the time, I remember taking pictures and thinking I'll add it to my teaching files, but today we can do better in shorter period of time, and I'm going to show you how. So here is her young daughter who came in 20 years after treatment. We intercept her at a much earlier age, and here we have 20-year records on the daughter. And we could see even on her, she was a class 3, different to her mom, and you could see the convexity change, the mandible. If you don't get full smile at age 14, it's going to be even less. The lip continues to grow 1 millimeter every 10 years. And again, looking ahead long term, we have a stable occlusion, but you can almost feel like there she is at 25 years, 11 years post-retention. You can almost feel like that class 3 tendency and the delicacy of those lower incisors at that age. And so about 10 years ago, I expanded our orthodontic practice in the Pacific Palisades and established what Carl talked about, an interdisciplinary, multidisciplinary type of a center, where I began to develop close relationships with plastic surgeons and orthognathic surgeons, with ENT, and there was even a time called where we had a nutritionist, and we had an exercise physiologist, and they weren't so much in-house, but there were close affiliations to try to look after the patient a little more completely. So many people came in having pain, and the mechanotherapy that sometimes we were using against them was not quite as important as some of the more medical modalities. And we called it Face Center Los Angeles. It's about 2 years later, I decided to bring in the plastic surgeons, and I scoured the US to try to find what I felt would be double-degree people. We recruited 2 surgeons from Stanford and built a AAA HC operating room right in the orthodontic office, which is there today. Full sterilization over there. We have a seminar room where there's monthly continuing education courses now that people come in and visit and take, and please we welcome anybody who would like to come and visit up there for those. We would have the full imaging that you talked a little bit about, Carl, with the 3D right in-house, and with the 3D DI and 3D MD 2 stations over there, so that we could put together what later you'll see is a patient-specific anatomical reconstruction of the patient right there in the office. For the young kids, we would have a VIP waiting room for some of the patients that were traveling from far, or some of the people that were going through orthognathic surgery that would be separate from the main reception room. And then in most of the rooms, we built 8 private rooms, and then there was still the open bay for the kids, because they enjoyed the camaraderie and the interaction with all of their fellow kids over there. And our goals essentially were not very different from what all of, I'm certain your goals are: improving results functionally, aesthetically, and trying to reduce the time, chaired side time, the overall time, the operating room time, and the recovery time. And enhanced results included enhanced facial and smile aesthetics, enhanced occlusion, enhanced stability, enhanced periodontal and stomatic health, and enhanced patient satisfaction. And so we developed a series of protocols, and I would like, for today's purposes, in the short time we have this morning, to discuss 3 of them that I thought may be of most interest to you. One with respect to the face, the second with respect to the airway, and the third with respect to the teeth and the occlusion. One of the secrets that I always feel like is sometimes overlooked is the quality of the staff. Over the years, we have really tried to hire more educated staff members, and more than half of them have college degrees. My manager's an MBA business. I have my 2 receptionists are journalists, as it turned out, answering the phones. One of them from Australia, one of them from UCLA, pre-screened already. And many of them have been with me for 15 and 20 years. Many have gone on to become other things, including dentists, one an orthodontist, 2 of them physicians, lawyers, and on. But it really has helped. I hear a lot of my colleagues complaining about the things, and having the quality of the staff really, in my mind, has been an important secret to enhancing the overall quality and satisfaction of the patient and the quality of the result. how many patients, how many dentists come into your offices every day and bring you a set of handheld models, or sometimes with the articulators and sophisticated like the Stewart pantographic. And as orthodontists, we've embraced worldwide, thanks to Carl Rick and many of the other people going back all the way to broadband progressively. I think cephalometrics has really helped us tremendously in being able to navigate and circumvent and add to as a useful tool. And each of us has our favorite cephalometric analysis, but cephalometrics is not without limitations, as any tool is. And Graeber was one of the local critics. How many thousands of bicuspids have been unnecessarily extracted because of cephalometrics. We know the problems from the literature of distortion, magnification, superimposition, and generally cephalometrics is not a very good measure of a patient's face. And so we've added a component that I've found most helpful and called it a prosometric analysis. It's from the Greek word prosopos. It's just a 3D aesthetic template, and additionally three-dimensional cephalometrics. Part of the problem, as you all well know, is sometimes you can accomplish your occlusal objectives, but not necessarily your facial objectives. And here's a dramatic example with a flattened profile and the rich profile that people don't like. Maybe less, it almost looks like the mid-face is being reduced. But when you look at the tweed triangle and you look at some of the 25 points of contact occlusally and the plaster on the table, it looks pretty good, even from an American Board of Orthodontics standpoint. So a prosthodontist trying to make up for it will do a full veneers, they'll do a nose, they'll do a chin, but it never quite really cuts it. It doesn't really do the justice. It doesn't really look good. Here's a young lady who walked in, and she had, it turned out it was a lawsuit, and I was actually defending the orthodontist, and he had taken out 4 bicuspids, and as much as some of us may not agree with it, it's not below the standard of care, and the occlusion was really good, and we felt like he had done nothing wrong. But she was very unhappy, and I agreed to take her as a patient as long as she knew that I was going to be an expert on the orthodontist side. And she agreed to allow me to do it, and she ended up losing the case. And the orthodontist prevailed because it was a very good functional occlusion. But listen to her story. She brought me in this picture of what she looked like when she was younger. Here she is now, and listen to her story.
Back. My face started to sag. It's kind of like someone let the air out of your face. It became very deflated, and my cheeks became hollow and saggy. I developed these dark lines. I would look in a mirror and it would look as though someone painted black lines down my face as this part of my mouth retreated and got smaller. My lower arch.
And you know the rest of the story. So here she just didn't like the results of how it looked. And so we've learned as orthodontists to be very careful about extracting permanent teeth, particularly in an adult, particularly if you're going to reduce the precumbency along the lines of what she was talking about. Let's see, so facial analysis is as old as human mankind. When you look in the literature, it's not new. Here you see a little excerpt from a chapter that I wrote in a book. The human face is a drama of flesh, architectonic structure of skeletal and muscles, a musical arrangement of ellipsoids and undulating arcs. It was written by Maureen Malarkey. That's my fellow countryman, Therese Theron. And I was always fascinated, like I'm sure many of you are, with the human face, but I really became interested more as a student in my training at UCLA when we started studying cephalometrics. And in my first few weeks of the training at UCLA, these 2 little craniofacial dysostosis cruisons, patients came in, little Michael and Michelle, with the bulging of the eyes as the brain continues to expand and the sutures are not releasing, with the maxillary insufficiency and the relative mandibular prognathism. On little Michael, we were able to do some orthopedics, but with Michelle it was so severe and there was some danger of blinding of the eyes that we ended up sending her to the OR room. Carl, this was Henry Kawamoto years ago, and Tessier was on the OR, and it was a real pivotal experience in my training, where I had taken the course from Spiro to Conus, and I learned the cephalometrics, and I had it all laid out in the operating room. Spent weeks putting it together and making sure it was really good. And I remember Tessier coming over one time and looking at it and nodding, thinking, you know, nice job, son. And hardly looking at it the rest of the operation. And it was an 8-hour operation. Henry Kawamoto was on the hip, he was up there, and it was quite dramatic. There you could see the beaten silver appearance of the skull. You can see it in the radiograph as the brain continues to expand and it resorbs it. They took the rib, they build it out, they move it forward. And there you see her pulling the, making the release where they pull it all forward, building on the rib and fixing it. And he came to me afterwards and he said, I asked him, I said, you hardly looked at the cephalometrics, Dr. Tessier. And he said to me, what we really need is a facial analysis. And I thought about it, and it impacted me a lot. I still do cephalometrics, I still use it a lot, but in orthodontics, we've concentrated a lot on the profile, the Steiner line and the E line, and we know that day to day we're not looking x-ray to x-ray, we're looking face to face at each other. I'm an artist and a sculptor. Here's a life-size that I recently completed. I made it in bronze, but in my early years I remember taking cephalometrics and trying to sculpt the face out of cephalometric data. It wasn't quite good. It wasn't quite helpful. Because cephalometrics is not really a very good indicator of facial aesthetics. In the early years, Dr. Ricketts popularized the golden proportion from the literature, made the golden dividers, and we did a lot of our research in the office, but in as much as it was a stepping stone in the right direction, it lacked specificity and sensitivity. And here you see, even in the subtle example of the morph from a woman to a man, how the golden divider can't really identify the differences. Certainly in some of the severe craniofacial anomalies, like this Treacher-Collins, it is a little less useful. And so what we began to do is we began to collect in Los Angeles all of the models that we could find. And we'd bring them together into the office, and we'd look at their portfolios, and we would reduce them down into these 10x8 photographs that we would standardize. And when you look at the literature, there's a lot of bias in the orthodontic literature. You see cases like this where people that are beautiful are included in some of the studies, but when you really look at them, for example, even that Bimax protrusion that you just said, there was a 4-bi extraction mixed in with a non-4-bi extraction. And sometimes the inclusion criteria were based on things other than facial aesthetics. When you look at some of the early studies, they were based on beauty queens, swimsuit, pageants, people like that, where they were judging it based on not necessarily the things that we would study. And so we would take these patients, reduce them down to composites that were quite specific to what it was that we wanted. We would take cephalometric radiographs, we would take away all the distracting parameters and just reduce it down to what we wanted to look at specifically. And we would reduce it further into black and white images, and we began to look for what it was that made a face beautiful. And we would hand it to a series of judges. Some of them would be orthodontists, some of them would be dentists, some of them would be lay people, and they say beauty is in the eye of the beholder, and yet there seemed to us to be a certain consensus in Japan or China. If you give a beautiful person to that person, they'll tend to judge it as beautiful. And we developed a Likert scale where we could take patients and did a study at UCLA where we could slowly move them a little bit up on the Likert scale. When you look at the literature, the psychological literature, patient judge of beauty is as good as any of the science that there is. And this is one of the pioneers. He's Leslie G. Farkas. He was an anthropologist and a plastic surgeon and ENT up in Canada. He did a lot of the early work. This goes back, way back, where he wrote me a really wonderful letter. Carl, this is interesting, where he says, "Thank you for your kind letter. Your idea is excellent to show the surface measurements and the corresponding skeletal structure. I've been dreaming about such a study. Today we have that technology." He would sit painstakingly for years and measure it on everybody, and has a beautiful book that he contributed to the literature and came out with, and what was so interesting is, as giant as he was in the profession, he credits Hardlicker with these ideas. He published it 72 years before him. And so at the time we developed the digigraph, where you could pinpoint points on the face. There were 4 little microphones up there, which would register it, and you could go ahead and do a facial analysis that was one-to-one. Facial analysis was not really a cephalometric analysis, and so we would do something backwards at the time. We would take algorithms and take a very accurate analysis and make it look like a cephalometric analysis so that orthodontists would embrace it, which was backwards, really, in a way. And we would even take the models and try to digitize those and put together what we felt like was the best we could do in a patient-specific anatomical reconstruction. And so I wrote in my book about the various planes of the head, and it was my attempt, using that concept of proportionality, to come up with things that would be useful in a 3-dimensional analysis. And at the time I thought it was good and used it for a number of years. And here you see the proportion rather than the absolutes, and we put the hard tissue and the soft tissue in the book, and I was feeling quite good about myself. But as over the years I began to think about it and try it on patients, I realized more and more that even that really was not good enough. It was very obvious, and more so as we got further into it, that we live in a complex age where people really do have different beliefs, they have different opinions, they have different wants and different needs, and cephalometrics is average. One person's smile is completely different to the others, and one person may not want to look like that one person, for whatever reason, based on their own cultural or personal beliefs. And everyone is an individual, everybody is different, with different opinions, different preferences, and they have very much different morphology, and we embrace that.
I hope that means seen that as a king living up his game in times of big time doing it.
If you talk about elevation to a world right now.
There we go. Here comes Kobe's style. This kid is going to be something.
Yeah, and there we have, you know, $70 million contract, and he looked at me like I'm crazy when I'm starting to talk to him about a genioplasty. He loves it. He's happy as how he is. Same with Jay Leno, and same with many, many other people. And Carl talked about, you know, embrace the individual and don't treat people to cephalometric norms. And so we began to use the Bolton standards as a framework and as a basis. We included the library of patients that I had treated, more than 10,000 that I'd personally worked up. These are not even including Dr. Ricketts' patients that are at Loma Linda and archived by Rocky Mountain that some of you have access to. We included 49 Academy Award winners, 2 Miss Universes. We just picked up another one recently, Miss Worlds, Miss USAs, and models in our library. And we began to make a 3D aesthetic facial template. That was a computerized template that would allow us to, rather than look at averages of 1,000 faces molded into one that you see over here, give us a much more individualized type of a mask that could be placed over a patient's records to compare against. And we're not trying to clone the patient, but try to ask them what it is that they liked or didn't like. And so we would take many of these beauty pageant people with normal occlusions, and we would put them into the composite and have a series of masks that we could fit over the patient and be able to apply to them. You could make modifications in the mask based on race in terms of any of the parts of the face. And came up with then a facial, let's see, a patient-specific anatomical model. So at the chair side, we would begin the process with our clinical exam. It would include a facial exam, and at chair side, we would go ahead and documented along the lines that, a little differently, but along the lines that Carl was talking about, in order to create what we wrote about as a patient-specific anatomical reconstruction of that patient that we could use. And using that, we would sit and consult with them with what is possible and what is preferable. We would evaluate the patient, educate them, and try to come up with something a little bit more specific for that individual. Here's a good example of it. A woman came in for a small periodontal condition. She had a little recession on the front teeth and taking really good records. You see the mentalis strain, the dolichocephalic look, the retrognathic mandible, the long lower facial height, the microrhinodysplasia, and you could see it a little bit more evident, the shiners of the eyes, and almost that long face syndrome.